Hi, we are group number 11, Barbara Lightning, who has multiple sclerosis. The members of our group are Cody, Andrea, Rebecca, and Chris. An introduction to our case. The patient was referred to home health PT after recent hospitalization secondary to an exacerbation of MS. She is currently homebound and unable to get out of the house. She has had MS for 30 years. She currently uses a rolling walker for ambulation. She describes her income as fixed, secondary to an unreliable ex-husband. She currently resides in a one-story apartment that has a ramp to enter, but considers her apartment not handicap accessible, and it has narrow hallways and a galley-style kitchen that makes it difficult for her to get around using her walker. Some of the body structure and impairment issues we have going on with this patient: she has a right visual field deficit that interferes with peripheral vision. She also notes diplopia during exacerbations. She currently has decreased tone and strength in her trunk, as well as decreased strength, impaired sensation, impaired proprioception, and paresthesias in both lower extremities. She has a right foot drop with ambulation and a mild ataxic gait, and also she is limited by fatigue. Some cognition and perception issues: she is A&O times 3, but easily distracted, impaired divided concentration, memory issues with immediate recall. She can be impulsive and has impaired judgment, leading to some safety concerns, and she also has difficulty problem solving. Her activity abilities: she can roll independently in bed, she can bridge, she is independent with all toilet mobility, she can bathe independently, groom independently, she can stand still using a walker, and she eats and cooks independently. Some limitations she has: functional mobility is limited by decreased balance and strength, mainly in her lower extremities and trunk. She has difficulty with certain transfers, such as supine to and from sitting and sit to stand with her walker. She is also limited with ADLs and IADLs, such as laundry, shopping, cleaning, dressing, and driving. Participation: her abilities there: she can use a portable phone to make calls, and she maintains contact with friends, as friends have agreed to help drive her to appointments. Some limitations she has with participation: she isn't getting out into the community and being as involved as she would like, mainly because of fatigue, and she is not engaging socially. Some environmental factors to consider: she lives alone. She has an apartment that is not handicap accessible and is limiting her mobility. Some personal factors: she loves being social and currently is not able to do so. She had a difficult divorce and is not on good terms with her ex-husband. She does have a son who lives in a nearby town, but he does not visit regularly. But she is motivated to improve her functional independence.
Okay, now we're going to look at some examination tools that may be used for patients with MS. And I am sick, so please forgive me. So some examination tools are specific to MS, such as the MS Quality of Life Inventory, the Functional System Scores, the Expanded Disability Status Scale, and the Modified Fatigue Impact Scale. Other more general tools are also used to assess limitations associated with MS. For example, the BERG can be used to look at balance, the FIM to look at functional mobility, and the Mini-Mental for testing cognitive ability. I examined a balance evaluation tool called the Balance Evaluation System Test, or the BESTIS. This study I found looked at the use of the BESTIS specifically in individuals with MS. It was an applied quantitative research study that compared the use of the tool with MS populations to its use with participants with no known diseases. It also compared the BESTIS to the EDSS to determine sensitivity, specificity, and accuracy in identifying a history of falls in those with MS. Lastly, the study also examined the outcomes of the BESTIS to outcomes from objective lab measures, which included tasks of step initiation, leading to limits of stability and postural responses. The results show a significant difference between BESTIS scores of those with MS and those without MS. BESTIS scores correlated with EDSS scores, and it was able to correctly determine fall history. BESTIS scores also correlated with all objective measures, with the exception of peak anticipatory postural adjustment amplitudes. Based on these results, the study concluded that the BESTIS is a valid tool for evaluating balance in MS populations. The strengths of the study included participant characteristic matching between the participant groups, the use of objective measures for comparisons, and the use of a control group. The limitations included a small sample size. They had 13 in the MS group compared to 13 without MS. Varying levels of severity within the MS group. A lack of detailed information concerning the characteristics of the control group and the MS group, and limited comparison to other clinical assessment tools. Future research with more detail, a larger population size, more consistency within the MS group, and comparisons to additional validated tools and/or additional objective measures should be conducted to provide stronger support of the use of the BESTIS with MS populations. Concerning overall support for the BESTIS, I found other studies looking at the BESTIS with healthy populations and with patients with Parkinson's disease. The study with the healthy population found that the BESTIS correlated with the ABC scale for balance confidence and is reliable and valid. The study with patients with Parkinson's disease found the BESTIS to have high inter-rater reliability, high retest reliability, the best validity, highest sensitivity for identifying patients with identifying fall patients when compared to the Berg, the ABC, and the FGA. Okay, here is a list of the patient's goals. As you can see, she is most concerned with being independent with self-care tasks and being able to return to the community. So here is a list of our short-term and long-term goals for the patient. Our short-term goals consist of some educational goals and referral goals, as you can see here. Educational points are aimed at addressing the patient's fatigue and safety issues. For example, the patient commonly ambulates with the walker while using one upper extremity to talk on a cordless phone, which creates a fall risk. Also, it would be beneficial for the patient to have an orthotic device to prevent foot drop on the right. And for exacerbations, the patient may find that a scooter allows her to continue enjoying life outside the home. The referral goals are to address mild urinary incontinence and nutritional habits because she seems to only prepare light meals such as toast or frozen dinners for herself, which may lead to nutritional issues. As for long-term goals, the patient wishes to achieve more independence with self-care and functional mobility, as well as to get back to social activities. So the remaining PT goals, as you can see here, are aimed at helping the patient achieve her goals by improving balance, managing her ataxia, and improving her strength and endurance.
You guys will have to be patient with me as well. I'm just getting over a cold myself, so sorry about that as well. According to the APTA, there are certain things that you have to consider with each case. I've listed them here. And then we went another step and kind of mentioned a few of the things that you can do to address each of these areas. So aquatic PT, Frankel's exercises, which if you're not familiar with, are coordination exercises essentially. PNF, hippotherapy, and breathing and relaxation techniques are all different ways to address these different areas. We put together a sample intervention, warming up for 5 or 10 minutes as well as cooling down for 5 or 10 minutes. Strengthening for 10, coordination for 10, transfer training for 10, and gait for 10. We decided to use, for coordination, either Frankel exercise or PNF, depending on the day or your time constraints. So the Frankel exercises, again, are just basically coordination exercises. We're going to use them with walking and stairs and those types of things. So we're kind of getting that and our ambulation exercise for the day at the same time. We're also considering using PNF patterns, both D1 and D2, upper and lower. Repeated contraction, so we're looking at strength, endurance, and coordination. Doing the transfer training, Gait, we talked about adding cuff weights on their ankles to improve that proprioception and also gives them a little bit of resistance. And then also focusing on their ambulatory aid practice, so their rolling walker practice, things like that. Home exercise program is Kegel exercises. They're doing those probably 3 times a day. We can progress each one of these in a different way. So strength, you can increase resistance, set repetitions. Coordination is taking away one of their 3, so somatosensation, vestibular, visual. Transfer training, make them do it more. Add the resistance, whether it's manual or otherwise. And then gait training, you can blindfold them and increase the amount of distance they have to walk and so forth. The one consideration with this patient is that intervention should not be so taxing on them that they can't go on the rest of their day being functional. There's also a piece of patient education with this patient. We talked about their chairs are all on wheels, so that might be a consideration to address. Try to get her to stop carrying her phone in her hand while she's using her rolling walker. She has area rugs that need to be removed. She seems to always dress in a swivel chair, which causes her to almost fall over every time. And then ideas to manage her diplopia. So maybe an eye patch or something, so she's only getting one visual field or one visual input, or teaching her how to recognize what's true and what's a false visual. Also, this patient might benefit from some kind of activity log or something so that she can pace herself throughout the day to remain functional as long as possible. I looked at a study where they did aquatic therapy with patients. There were 21 participants in it. They were all taken from one MS organization, MS Society, and they were all females, so that really hurt the external validity since it's a small sample size or a small study size and a small sample. But it's a randomized controlled study, and they used modified fatigue impact scale and the quality of life 54 questionnaires or outcome measures, which are both well recognized and accepted measures. There were 3 aquatic therapy sessions a week. Each lasted 60 minutes. They had a target heart rate of 50 to 75%, and a pool temperature of 82 to 86, and they did find statistically significant improvements in both the fatigue and quality of life for those patients doing in the aquatic therapy group compared to those that were in the control group.
Okay, so as we said before, Barbara has a right foot drop that affects her gait, and this is actually a pretty common impairment for individuals with MS. A common intervention designed to address this problem would be prescribing an AFO. I actually looked at an article that investigated the use of functional electrical stimulation instead of an AFO as a way to treat a unilateral foot drop. And this study was performed by a group of researchers from the UK. They were led by Barrett, and they compared the use of functional e-stim to therapeutic exercise for adults with a unilateral foot drop. And as you can see, 44 subjects completed the study. The selection criteria was pretty strict for this study, and individuals had to be adults with a diagnosis of secondary progressive MS, a rating of 4 to 6.5 on the EDSS, unilateral foot drop identified by a clinician, a good response to e-stim of the common fibular nerve, and no previous use of functional e-stim. And this was a 2-group randomized clinical trial, as I said before, and as such, we ended up with 20 people who completed the study in the functional e-stim group and 24 individuals in the exercise group. And individuals in the functional e-stim group were given an odd-stacked dropped foot stimulator, which is just a functional e-stim unit. When somebody would take a step, it would either kick on or off a transducer stimulating the common fibular nerve. And the individuals in the exercise group were evaluated by a physiotherapist, and then they were given specific exercise programs to complete at home. And individuals in both groups were assessed at baseline, 6 weeks, 12 weeks, and 18 weeks. This was an 18-week study. And at each assessment, the parameters for the E-stim or the exercises themselves were adjusted as necessary for each individual. And for each 6-week assessment, the primary and secondary outcome measures were measured, which include a self-selected 10-meter walking speed, the PCI, which is an energy efficiency with gait. It's actually measured in heartbeats per meter walked, and then also the 3-minute walk test. And each individual completed these at each assessment, and they were allowed to use any walking aid they wished, but they had to do it consistently. And then after the study was completed, researchers found that there was no significant difference between groups in the PCI or 3-minute walk test from baseline to the final evaluation. They did find, however, that the exercise group had a significantly greater improvement in self-selected 10-meter walk speed from baseline to completion of the trial. And they concluded that functional E-stim used without any additional intervention isn't more beneficial than therapeutic exercise for gait characteristics in people with MS. There were a few flaws, in my opinion, in this study, however. The first is that functional E-stim was used without any additional interventions whatsoever, and this isn't realistic for an actual MS patient. If we chose to use functional E-stim over an AFO, we would also have the patient do some sort of exercise. So in reality, they did not do a good job of comparing in a clinical way.
One possible physical therapy intervention that could be useful for our patient would be hippotherapy. In a research article done by Hammer, they used a single subject design type ABA, meaning they took pre-intervention measurements. They did the intervention of hippotherapy, and then they took post measurements, and they compared each individual to themselves, so there wasn't a control group. The measurements that they used were balance, gait, spasticity, functional strength, coordination, pain, self-rated level of muscle tension, activities of daily living, and a health-related quality of life. The hippotherapy sessions, there was one a week for 10 weeks, 30 minutes each, that were individualized by physical therapy to each participant. The results of this study showed that 10 out of the 11 participants improved in at least one variable, sometimes more. Balance was the variable that was most often improved and had the greatest gains. Other improvements were seen in pain, muscle tension, and activities of daily living. Also, gait velocity improved. The conclusion the researchers made after this study is that hippotherapy is beneficial to patients with MS. The main limitation of this study is that it was a small sample size, and as individuals with MS can present in very different ways, it's important to keep that in mind when treating patients. For Barbara, our patient, we would suggest one 30-minute hippotherapy session per week for 10 weeks, with the goals of increasing her lower extremity strength and her trunk strength, improving balance, and improving her functional ambulation. Some treatment ideas we could use for her would be to simply ride in a normal saddle just to get used to the horse's movements for a while and to help with gait through that. We can also have her stand up in stirrups and sit back down, working on the sit-to-stand movement and increasing her lower extremity strength. Trunk rotation activities could be useful to improve her trunk strength and her balance, and side saddle is another position we could use for her balance.
Alright, so now we've come to Barbara's rehab potential, and we are going to consider her age-related changes and comorbidities within this. As far as her age goes, Barbara is in her late 50s, so she is past what you consider her physical peak, and you would be expecting to see some age-related changes at this point, but I would think that they would become more of a factor in years to come. With that said, her lack of mobility may accelerate her loss in bone density as she ages, and this could predispose her to fractures with falls or trauma, and with her impaired balance, it's pretty likely that she will experience falls unless she always uses the proper assistive devices and has a really good environment around her. Her changes in her visual system will expect her lens to start thickening. She'll experience presbyopia. This may exacerbate the visual field cut that she already has and lead to significant visual problems in the future. She's also past her peak for cardiovascular and pulmonary function, as well as, if she were completely healthy, her neurotransmission speeds. And the cardiovascular and pulmonary function, however, will contribute to her lack of endurance and fatigue, in addition to the fatigue that she experiences due to MS. And then finally, she is past her age for optimal skeletal muscle strength and neurotransmission, as I said earlier, and this could contribute to some of her muscular weakness that would normally be just attributed to MS, but the aging process could affect this as well. And then as far as medical comorbidities, she seems to be fairly healthy, but we really need to consider her psychological and emotional status. She's living alone, she's divorced, and while she does seem to have really good friends, there's the possibility for depression and emotional issues in general, which will affect her overall cognitive status and how well she'll work with us as well. And then, in addition, she's moving more than likely with impaired movement patterns at this point, and this could increase the stress on her joints, leading to potential pain and joint damage, arthritic changes, especially in her hips, knees. And this also causes greater energy demands for normal mobility, which will again exacerbate her fatigue issues. Despite all of this and the fact that she does have a progressive disorder, I would say that she has a fair overall rehab potential.
All right, that concludes our presentation. Thank you for listening. I'm going a couple minutes over here, so I'm just going to leave you these take-home points to review on your own time and our resources.